Can any one of you tell me what is the treatment of ulcerative colitis? Which drug is used to induce remission? In ulcerative colitis. Which is the first line drug to induce remission in ulcerative colitis? I need quick answers so that we can move quickly. Mesalazine. Mesalazine, oral mesalazine or topical mesalazine?
Sorry, topical mesalazine.
Topical mesalazine. And if there is no improvement with topical mesalazine, then which drug you will use?
Mercaptopurine.
Mercaptopurine, we are talking about to induce remission. Mercaptopurine is always used in the maintenance of remission. So if there is no improvement with topical mesalazine, then we will use oral mesalazine. So to induce remission in ulcerative colitis, we prefer rectal or topical mesalazine. What's the reason? The reason behind that is that ulcerative colitis is mainly limited to rectum or to the maximum to sigmoid colon. It never extends beyond sigmoid colon. So it is mostly a limited disease which is limited to the rectum. So the first line drug is topical mesalazine. And if there is no improvement in symptoms, and if there is no effect with topical mesalazine in 4 weeks, then we will give oral mesalazine. So in ulcerative colitis, the first line drug is in moderate to mild ulcerative colitis. The first line drug is topical mesalazine or rectal mesalazine. And if patient is not responding, then oral mesalazine. And how to manage a case of severe ulcerative colitis? Which drug is used in the management of, which is the first line drug to induce remission in severe ulcerative colitis? Anyone? In mild to moderate ulcerative colitis, rectal mesalazine is first line. If no improvement, then oral mesalazine. And in severe ulcerative colitis, which is the first line drug to induce remission?
The steroid?
Yes, IV steroids. IV steroids, not oral steroids. IV steroids in severe ulcerative colitis. So to induce remission in mild to moderate ulcerative colitis, rectal mesalazine. If not responding, then oral mesalazine. And if there's severe ulcerative colitis, now can any one of you tell me what is the criteria for severe ulcerative colitis? What is the criteria for severe ulcerative colitis? What is the criteria for severe ulcerative colitis? Anyone?
Is it more than 5 episodes of loose stool with blood per day?
5 episodes.
It's a rule of 30, like more than 6 episodes of
Of 6, 30, and 90.
6, 30, and 90, sorry. So 30 ESR and 90, I think it's heart rate.
Yes. And 6 episodes of diarrhea.
Is more than 6 episodes of diarrhea.
Yes. So
Yeah.
yes, remember the rule of 6, 30, and 90. 6 or more than 6 episodes of diarrhea with visible blood, ESR raised more than 30, and tachycardia, heart rate more than 90. Then we will say that it's an acute flare of ulcerative colitis or severe ulcerative colitis, and we'll admit the patient for IV hydrocortisone. So now we have discussed about how to induce remission in ulcerative colitis, how to induce remission in mild to moderate ulcerative colitis, and how to induce remission in severe ulcerative colitis. Now, to maintain remission, which drugs we will use? Which is the first line drug to use for the maintenance of remission in ulcerative colitis?
Mesalazine?
Mesalazine, that's right. Oral mesalazine, to be more precise. And if no response or not maintained with oral mesalazine, then we will use azathioprine or mercaptopurine. So to maintain remission in ulcerative colitis, we will use oral mesalazine. If does not work, then we will use oral azathioprine or oral mercaptopurine. So now we have revised that which drugs to use to induce remission in ulcerative colitis and which to use to maintain remission in ulcerative colitis. Now come to Crohn's disease, which is the first line drug that we use to induce remission in Crohn's disease. Which is the first line drug to induce remission in Crohn's disease? Anyone? Anyone?
Oral steroids like prednisone.
Yes, oral steroid like prednisolone. And if prednisolone is not given in the option, then budesonide. And if both of them are not given in the option, then you can pick mesalazine. So the first line is oral steroids or budesonide, which is also a potent steroid, is an alternate. But if both of them are not given in the option, then you can pick mesalazine. But if mesalazine and steroids are given together, then you will pick steroids, oral steroids, to be more precise. So to induce remission, oral prednisolone is the first line, and to maintain remission, azathioprine or mercaptopurine are the first line drugs. And as I shared an MCQ on the group, that stopping smoking is a very important in the treatment of Crohn's disease. When
Is
we
that
can
smoking-
decide,
Sorry, is it smoking? Is it a risk factor or it's just like uh, people who are smoking, they are prone to
People
bone
who are
disease?
smoking can say that smoking worsen the ulcerative colitis, while smoking improves the symptoms of, sorry, smoking worsen the Crohn disease and it improves the symptoms of ulcerative colitis.
Okay, thank you.
So when we can decide that it is severe ulcerative colitis, we have already discussed this rule of 6, 30, and 90. More than 6 bowel movements a day with visible blood in large amounts, ESR more than 30, heart rate more than 90, temperature 37.8, more than 37.8, and anemia. These are some features of severe ulcerative colitis. Now, there's another scenario: history of indigestion, long history of NSAID intake, sudden onset of severe abdominal pain, abdominal rigidity, absent bowel sounds, lying motionless. What is the most probable diagnosis in this scenario? Someone with a history of NSAID intake present to you with abdominal pain, rigidity, and absent bowel sounds.
Perforated peptic ulcers?
Yes, that's right. Perforated peptic ulcer. How will you confirm your diagnosis?
The absent bowel sounds and
Which investigation you will perform to confirm your diagnosis?
chest X-ray. Sorry, abdominal X-ray.
Yes, erect abdominal X-ray will show gas under diaphragm. Treatment is fluids, analgesics, antiemetics, and surgery. Now, our next topic is hereditary hemochromatosis. Hereditary hemochromatosis is basically an autosomal recessive condition in which there is a mutation in the gene that is responsible for the absorption of iron. Which leads to increased intestinal absorption of iron, and increased iron is accumulated in the tissues. In which tissues it is most commonly stored? First of all, it is stored in the liver, skin, pancreas, joints, and heart. The main organ of iron deposition is liver. The deposition of iron in liver, excessive deposition of iron in liver will lead to hepatomegaly, and it will result in hepatitis, and it will damage the liver, which will eventually lead to cirrhosis. And cirrhosis is a risk factor of hepatocellular carcinoma. So you can say that liver cirrhosis or hepatocellular carcinoma is a complication of hemochromatosis. So deposition of iron will result deposition of iron in pancreas will result in damage to the pancreatic cells, which are responsible for insulin secretion. So the patient will also have diabetes mellitus. While the deposition of iron in the skin will result in hyperpigmentation of the skin, which is also known as bronze skin. Deposition of iron in joints will result in orthopathy, and in heart, arrhythmia, cardiomyopathy, and murmur and atrophy. So we can divide these complications of hemochromatosis in two groups. One group is the complication that can be reversed or reversible complication of hemochromatosis, and the other are irreversible complication of hemochromatosis. The reversible complication of hemochromatosis is skin hyperpigmentation and the manifestation of heart disease such as arrhythmia, cardiomyopathy, murmur, and atrophy. So these two complications are reversible complication of hemochromatosis, and liver cirrhosis, diabetes mellitus, and orthopathy. These three complications are irreversible complication of hemochromatosis. The basic defect in hemochromatosis is defect in the gene that is responsible for iron absorption, which leads to excessive absorption of iron, which is deposited in the body tissues and lead to organ or tissue damage. In the exam, usually a triad of symptoms is given in the Plab 1 exam, that is hepatomegaly, diabetes mellitus, and bronze skin. Remember this triad if you want to pick a scenario of hemochromatosis in the exam. Hepatomegaly, diabetes mellitus, and bronze skin. Remember that the liver is the most likely organ to develop cancer in hemochromatosis. So hemochromatosis is a risk factor for which cancer? Hepatocellular carcinoma. It is a risk factor for hepatocellular carcinoma. Now, there is a scenario as an example, a 40-year-old male, fatigue and SOB, diabetes mellitus and hepatomegaly. Now, a 40-year-old male present to you with fatigue and SOB, diabetes mellitus and hepatomegaly, and high ferritin level. So what are the hints in this scenario for hemochromatosis? One hint is hepatomegaly, other one is diabetes mellitus, and fatigue and SOB. It is due to cardiomyopathy because of deposition of iron in the heart muscles. It will lead to fatigue and SOB. And the final hint is high ferritin level. Ferritin level, which is a storage form of iron, it will be high. For example, 50-year-old male, skin hyperpigmentation, spider angioma, hepatomegaly, heart murmur, mild joint pain, diagnosed as restrictive cardiomyopathy. So deposition of iron in cardiac muscles will lead to restrictive cardiomyopathy. So this patient has a manifestation of skin manifestation and a liver manifestation, joints manifestation, and cardiac manifestation of hemochromatosis. Again, hemochromatosis is a risk factor of for which cancer? Hepatocellular carcinoma. Now, another example or another scenario, severe epigastric pain that radiates to the back and relieved when sitting forward, plus vomiting, plus history of gallstones or alcohol intake or a history of ERCP or trauma. What will be your diagnosis in this case? Epigastric pain that, yes?
It's acute pancreatitis.
Yes, that's right. The pain of acute pancreatitis, and remember that there's one other condition. The pain of pericarditis is also relieved by sitting forward. So a patient presents to you with a pain that radiates to the back and relieved when sitting forward with a history of gallstone, alcohol intake, ERCP or trauma. Your
Vomiting.
diagnosis will be acute. Yes. Your diagnosis will be acute pancreatitis. You will order serum amylase and lipase. Persistent dyspepsia, epigastric pain, especially at night in a patient who has never had any investigation or treatment for it. What will you do in this scenario? What will be the next best step in this case? A patient with persistent dyspepsia.
Check for H. pylori.
Before testing for H. pylori, is there any other thing that you can do?
Mm, PPI treatment?
PPI, not PPI, antacid treatment and lifestyle modification.
Yeah.
Antacids and lifestyle modification. If there is no improvement, if the symptom persists, then we will test for H. pylori antigen.
Sir, what about endoscopy? After H. pylori, we can do endoscopy.
Now we have done H. pylori testing and H. pylori is positive. H. pylori is positive, then we will advise triple eradication therapy. And after triple eradication therapy, if the symptoms still persist, then we will perform which test to confirm the eradication of H. pylori?
Urea breath test, sir?
Yes, urea breath test. If
You
that's
want
negative, then it means H. pylori is eradicated and there is some other problem. That's why the symptoms are persisting. Then we'll perform endoscopy.
Excuse me, sir.
GG.
I want to ask about endoscopy, that this is the protocol we need to do about after H. pylori treatment. We cannot do it before.
Yes, this is a stepwise management in a patient who is less than 55 years of age. Remember this one also. If the patient is above 55 years and he present to you with dyspepsia, then you need to perform endoscopy to rule out any esophageal malignancy. This is the protocol that we will follow in a patient who is less than 55 years of age and present to you with persistent dyspepsia. Now, that was one pathway in which H. pylori test was positive. What if the patient H. pylori test is negative? Then we'll prescribe PPI. And if the symptoms of the patient improves, then there is no need to do any other intervention. And if even after if H. pylori test is negative and the patient does not improve with PPI, with trial of PPI, then again we will perform endoscopy. Is it clear, everyone?
Sir, the protocol of endoscopy, can you please repeat it again?
There are two pathways. A patient who present to you with dyspepsia and his age is less than 55 years. Then the first thing that you need to do, the initial best step would be to prescribe him antacid and lifestyle modification. If the patient symptoms improves, then there is no need to do any further investigation. But even after antacid and lifestyle modification, the patient condition does not improve, then you will perform H. pylori test. Now there are two pathways. Either H. pylori test will be positive, either it will be negative. If it's positive, then we will prescribe him triple eradication therapy. And if the patient symptoms improve, then no need to do anything. But if the patient symptoms persist, then you will confirm the eradication of H. pylori by urea breath test. If urea breath test is positive, then you will again prescribe him triple eradication therapy. And if it's negative, then you will go for endoscopy. Because even after eradicating H. pylori, the patient's symptom is not improving. It means there's some other problem in the esophagus, which we need to identify through endoscopy. Now, what is the other possibility? If at the initial testing H. pylori test is negative, then what will you do? You will just simply prescribe PPIs, give him a trial of PPIs, and if his symptoms improve, then no need to do anything further. But even after PPI, if the patient symptoms does not improve, then you will perform endoscopy. Is it clear now?
Yes, sir.
Again, a scenario of vitamin B12 deficiency. Now, answer this question. Chronic diarrhea recently becomes bloody, aphthous ulcers, left lower quadrant tenderness, no weight loss. What is the most likely diagnosis? A patient with chronic diarrhea, which recently becomes bloody, with aphthous ulcer, plus left lower quadrant tenderness, no weight loss. What is the most likely diagnosis in this scenario?
Ulcerative colitis.
Ulcerative colitis.
Ulcerative colitis.
Yes, it's ulcerative colitis because the patient is having left lower quadrant tenderness. Ulcerative colitis, the points in favor to ulcerative colitis in this scenario is left lower quadrant tenderness, no weight loss, because in ulcerative colitis, usually there is no weight loss. The diarrhea is bloody. And aphthous ulcers are present in both Crohn's disease and ulcerative colitis, though they are more common in Crohn's disease, they can also be present in ulcerative colitis. So this one point was favoring Crohn's disease, but all the other points are in favor of ulcerative colitis. Weight loss is also common in Crohn's disease and not common in ulcerative colitis. So it is, yes, it's ulcerative colitis. Bloody diarrhea in favor of ulcerative colitis. Lower quadrant pain in favor of ulcerative colitis. No weight loss is also in favor of ulcerative colitis.
Can I ask a question about hemochromatosis?
Yes, you can.
It's just that is this hemochromatosis, it can occur in young age people as well.
Yes, it can occur in young age people as well.
And also, is it picked up incidentally, or is it like, I mean, like some people, they don't even have this, and if they have their full blood count done, and then they come to know that
No,
they
it,
have.
it is usually picked when there is manifestation of this disease. It is not usually picked incidentally. So it will be picked only when the disease manifests itself.
So is there any symptoms like patient complains that he when he's eating, he suddenly feels like that he's got everything feels like very bitter in taste. Could that be one indication for hemochromatosis?
Bitter taste is, you cannot say that it can be an indication of hemochromatosis. But yes, there can be some generalized symptoms like nausea, abdominal pain, because of
Yeah.
deposition of iron in the liver.
Okay. Okay. Yeah, that's fine. Thank
Sir,
you.
hyperpigmentation is more common. Like, what is the first manifestation of hemochromatosis?
Hyperpigmentation is a reversible complication of. The more common is the most common organ that is involved. The first manifestation that can be liver, because liver, normally the iron is stored in the liver in the form of ferritin. This is the first organ that become affected in hemochromatosis.
Okay, sir.
Hyperpigmentation of the skin and cardiomyopathy, both of them are reversible complication of hemochromatosis. While liver cirrhosis arthropathy, and diabetes mellitus are irreversible complication of hemochromatosis. Okay. Any more questions? Okay, if no more question, then let's read this scenario. A 42-year-old male, dysphagia to both solids and liquids. Occasionally, there is a severe retrosternal pain. Barium swallow show dilated esophagus that tapers towards the distal end. What is the most likely diagnosis?
Achalasia.
Achalasia.
Excellent. The hint in this scenario was dilated esophagus that tapers towards the distal end. And
Yeah, the
also,
bird beak
dysphagia.
appearance.
Yes, yes, that's right. Achalasia. Yes. So, what is the treatment of achalasia?
Surgical dilatation.
Surgical dilatation. What is the name of that procedure that is performed in achalasia? The name of the procedure. Let's see who remember.
Manometry,
Manometry.
manometry with the great resting pressure, something like that.
Manometry is the investigation which we use to diagnose
sir.
the case.
It's not mano, it's myomectomy.
Myotomy. Myomectomy means removal of the muscle. Myotomy means
Yes.
yes, dilation of the muscles. Heller's myotomy. The
Heller's
name of the
myotomy.
procedure. The name of the procedure was Heller's myotomy. And the manometry is the gold standard investigation to diagnose achalasia. What will be the manometric findings in achalasia?
High pressure towards the lower end of the esophagus.
Yes, lower esophageal sphincter, there will be high pressure. Initial investigation can be X-ray, which will show a megaesophagus. Barium meal will show bird beak appearance, or the trachea will be narrow at the distal end. The most accurate test to diagnose this condition is esophageal manometry, and the name of the procedure is Heller's myotomy. What if someone cannot undergo surgery? Then what option we will have for the treatment of achalasia?
Stunting?
Stunting
No.
is the option only in end stage esophageal carcinoma. And is there any medical pharmacological treatment for achalasia?
Sir, antacids or
Botulinum.
Tell me. Yeah. Who is saying botulinum toxin? Injection
Yes.
of botulinum toxin because it will relax the muscles. It will relax the lower esophageal sphincter. So if a patient is old age and he cannot undergo a surgery, then you have the option to inject botulinum in the lower esophageal sphincter. That will also relieve symptoms. Now, tell me the diagnosis of this condition. A 40-year-old woman, a middle-aged woman with pruritus, jaundice, increased ALP, a known case of Sjogren syndrome. What is the diagnosis?
Primary biliary sclerosis?
Yes, excellent. Primary biliary cirrhosis. If a middle-aged woman present to you with pruritus, jaundice, and raised ALP, or a middle-aged woman with abnormal LFTs and pruritus, and there's a history of Sjogren syndrome, then it is primary biliary cirrhosis. When will you say that it's primary sclerosing cholangitis?
Ulcerative colitis, when the same scenario having ulcerative colitis.
Yes, when the same scenario having inflammatory bowel disease or most commonly ulcerative colitis, then it will be primary sclerosing cholangitis. Treatment of both the condition is same. The diagnostic investigation for both the condition are different. In primary biliary cirrhosis, it is anti-mitochondrial antibodies, and in the sclerosing cholangitis, it is ERCP.
Sir, please repeat again for primary biliary cirrhosis.
For primary biliary cirrhosis, it is anti-mitochondrial antibodies,
Okay, okay.
while
Sir.
for primary sclerosing cholangitis, it is ERCP. Now, if a middle-aged female with abnormal LFTs and secondary amenorrhea plus any other autoimmune condition, then what will be your diagnosis?
Autoimmune hepatitis.
Yes, autoimmune hepatitis, that's right. Now there is a scenario: a patient with history of peptic ulcer underwent surgery to remove the head of the pancreas due to cancer. A few days later, he developed abdominal pain with rigidity, tenderness, and guarding. So his ulcer become perforated after surgery. Remember that surgery is a risk factor for a patient who has a history of peptic ulcer and undergo a surgery. There's a chance that his ulcer can get perforated. Why? Because the stress during operation can lead to high production of gastric acid, which can lead to perforation of the peptic ulcer. So if someone present to you someone with a history of peptic ulcer,